So my name is David Tseng. I'm a first-year resident here at Cottage, and I'm going to be presenting on the myth of corticosteroids causing GI ulcers and bleeding. And just a quick little note, I know that's anabolic steroids causing that, but I just felt like that picture would be a little bit more memorable. A quick outline, I'm going to talk about a survey, kind of like what we just did, to see how prevalent the myth is right now. And then go into a little background about GI ulcers, bleeding, and corticosteroids, and kind of how I think the myth began and how it kept going, and a summary at the end of all my highlights. So this was a study done in the Scandinavian Journal of Gastroenterology back in 2010, and they looked at 360 physicians, including gastroenterologists and med students, and asked them if they thought corticosteroids were ulcerogenic. And circled in red is where gastroenterologists polled. And you can see there's a stark difference between what gastroenterologists think and the rest of the community. There's about a 30% decrease in what they thought, how ulcerogenic corticosteroids were. And this second question, which is important, is peptic ulcer incidence rate, and whether they thought it was rare or frequent. And once again, you can see there's a big difference between gastroenterologists and the rest of the community. And I want you guys to keep remembering this because I'm going to kind of talk a little bit more about incidence rate in the future. So a quick little background about GI ulcers and bleeding. The prevalence rate in the US is pretty starkly different from other parts of the world. The data that I saw was less than like 2% in the US compared to up to 13% in China. And that's largely probably due to H. pylori, which has a higher rate outside of the US. And the kind of association was discovered back in 1982. And NSAIDs, there's kind of a questionable discovery point of the association between the two. And I'll kind of go into that later. But those two cause a large majority of the ulcers. And then stress ulcers come in because it's kind of related to the debate that, at hand. And the thought that stress ulcers, the stress on the body, might lead to the stress formation. And specifically looking at how pathogenesis of this stress could lead to the pathogenesis of ulcers is kind of one of three things, or maybe a combination of them. Weakening of the integrity of the mucosal barrier, kind of like how H. pylori and NSAIDs do, impaired healing, and possibly increased acidity. So a little bit more background on corticosteroids. Back in the 30s, that's when they first started investigating ACTH, or adrenocorticotropic hormone. And back in 33, they were actually able to isolate it and use it to stimulate the adrenal cortex. And Hench and Kendall in the 40s used it in trials to treat arthritis with very, very successful results, and it actually led them to win the Nobel Prize in 1950. And since then, steroids have become kind of a miracle drug used to treat all sorts of things. And because of that, there was an increase in incidence of case reports of ulcers and bleeding of people on steroids. So that kind of led to the point, and the myth that I'm presenting today is corticosteroids ulcerogenic. So we all know that corticosteroids have a pretty wide range of effects all across the body. These are just kind of some of them. And you know, with such a wide range of effects across the body, you kind of wonder, like, what's the effect on the GI system? Sandweiss in 1950 looked at the kind of association between hormones and peptic ulcers, specifically looking at the hypothalamic pituitary adrenal axis and how it might be involved. And the reason why they started postulating this was because there was a kind of difference in incidence between men and women, and that incidence was actually the same before maturity. And things differed in menopause and in pregnancy. And actually they found that during active ulcer symptoms, there was an increase in urine 17-ketosteroids in the urine. So going along this, they kind of started thinking that there really is a connection with hormones and peptic ulcers. And they actually released case reports where instead of avoiding steroids, they actually used steroids to treat ulcers with very mixed results. And one of those case reports actually led to a perforation of the gastric wall, and was treated by a physician named Gray, who actually picked up on the myth. And he released several studies, one of which I'm going to go over. And he postulated that stress or exogenous steroids led to an increase in acidity in the stomach. So he wanted to kind of come up with a methodology, a study that could really look at how ACTH led to acidity. So kind of looking at this diagram, he postulated that stress led to activation of the hypothalamus and consequently the pituitary, and then ACTH, which they could supplement, and eventually adrenocorticosteroids leading to increased acidity in the stomach. And he specifically looked at the measurement of uropepsin, which is the urinary excretory product of pepsin. And he felt that it was proportional, so you can actually measure uropepsin to see the increased acidity in the stomach. So kind of going along the obvious route, he tested uropepsin excretion in people with adrenal diseases. So here in the red, I highlight the kind of most interesting findings. So this is the control. It's around 3,000. And in Addison's and hypopituitarism, which is adrenally deficient diseases, you see that there's a lower amount of uropepsin excretion. And when they supplemented it, it went back to normal ranges. And just to compare the other end, he included Cushing's, which is an adrenal excess disease, and it had significantly elevated levels. So this kind of proved the thought that ACTH and stress might actually lead to increased acidity of the stomach. So from then on, the myth kind of kept going. And the reason why is because, as I mentioned, steroid was a miracle drug. It was used in all sorts of diseases, and it was even used to treat GI ulcers, as I mentioned. And back then, they didn't really have really good treatment options. There was a high morbidity and mortality associated with GI bleeds. So it was very conservative management back then. It was like diet changes, antacids. They didn't have the H2 blockers and PPIs that we have now. And in severe cases, they even did vigectomies to try to lower the acid secretion. So in comes Spiro in 1960. He did a systematic review looking at these disease processes that were already known to be treated effectively with steroids. And he looked specifically at the incidence rates compared to the general population. And interestingly enough, he only saw the difference in rheumatoid arthritis. And when I was reading this, I kind of automatically started thinking, NSAIDs, they were probably on NSAIDs for rheumatoid arthritis. And lo and behold, a large proportion of the people taking the steroids were also on aspirin at the time. Scott in 1960 tried to find a way to actually measure blood loss, and he used radioactive sodium chromate, and he put it in stool. And the way he checked if this was a good method of measuring blood loss, he had patients ingest this radioactive sodium chromate and measured the vasculature instead to see if there was any leak in GI absorption, and he found that to be minimal. And he also did the converse or reverse and did injection of the dye or the radioactive sodium chromate into the vasculature and found that very, very little entered the GI system. So based on that methodology, he evaluated 124 patients over 30 days, many stool samples, and specifically looked at NSAIDs and corticosteroids. And he kind of did a mixed kind of regimen for each patient, and I'll show you kind of some examples. But overall, he only found three patient trials that ended up having measurable bleeding while on steroids. So this is one of the rheumatoid arthritis patients, and as you can see, they were on cortisone, hydrocortisone, triamcinolone, and wasn't very much significant bleeding that was measurable. But once aspirin was initiated, there was a clinically or measurable amount of bleeding in the stool. Another patient, rheumatoid arthritis as well, on steroids for about a month. And once he was put on aspirin, that's when he started being able to measure some bleeding in the stool. And when it was stopped, the bleeding decreased as well and came back up when it was reinitiated. Kahn and Blitzer in ~76, because there's no consensus to date, wanted to look at it a little bit on a bigger scale. They did the first major meta-analysis of 50 randomized controlled trials, placebo versus corticosteroids. And they found an increased incidence across the board, circled in red right here, about like 0.8 to 1 here, 0.3 to 1, 0.7 to 1 about. But all of those values were not significant. All the p-values were greater than 0.05. So it kind of begs the question if they made a type 2 error where they falsely retained the null hypothesis. So they kind of concluded that steroids don't cause bleeding. However, Messer in '83 tried to overcome that type 2 error and increase the sample size and had 71 randomized controlled trials and found very significant results. Very, very small p-values, relative risk rates compared to controls of 1.5 to 2.3. However, Messer's studies had very, very many faults. They didn't really control for other drugs. Things like chemotherapeutic agents were included. They also used an untrue double-blind study, and I say untrue because that study was a very, very poor randomization. It was very transparent. They just separated groups based on even and odd birthdays, so it was easy to determine which people were on treatment, which people weren't. And incidentally, this one study included 46 of the 57 total ulcers inside his meta-analysis. And another study that he actually did not include, the USPHS tuberculosis therapy trial, and that was the largest double-blind steroid therapy trial to date, would have helped his data a lot. There was poor diagnostic criteria in there. There was like really poor uniformity across the different studies. Some of them were diagnosed ulcers based on symptoms. Some were radiographically diagnosed. It's a poor uniformization. And they excluded patients from the treatment group, but not from the control group. And when they were inquiring about methodology from the studies that they included, they didn't really explore some of the ambiguous points. Khan is back. He was the guy who did the first meta-analysis, and this is in '84. He does a repeat of the repeat meta-analysis, and then the reason I say that is because he actually reused Messer's data, contacted all his studies, and reevaluated all of the values and addressed all the weaknesses that I mentioned in the last slide. So the first kind of adaptation, he subtracted 10 of the inappropriately included studies based on the faults that I mentioned earlier, and found that the studies, the results were not significant. And then interestingly enough, just subtracting one incorrect double blind, the one that I mentioned that had most of the ulcers, his results were not significant again. And then addition of the large tuberculosis therapy trial. This one is a little bit of kind of a estimation here. So they didn't have actual numbers for the study, but the study specifically said that the rates of the treatment group and the control were similar, and it was significant in that way. So what they did to include the data and include the large sample size was they used Messer's prevalence rate of about 2% and used a half for a minimum and a double for a maximum. And using either the minimum or maximum prevalence rate actually led to insignificant results. So it's kind of curious that just these small minor changes in Messer's meta-analysis led to insignificant findings. So Piper comes in '91, does a very good retrospective analysis because these are all documented GI ulcers in hospital admissions and in death certificates, and found that the estimated relative risk was about twofold in corticosteroid users in developing GI ulcers and bleeding. However, they also noticed that there was an association with NSAIDs, and after correcting for that confounder, they found that the relative risk was only 1.1 without NSAIDs. And they looked at the combination of the two and found it to be about a fourfold increased risk from non-users of either drug. So that kind of makes you kind of wonder about all the other studies I mentioned earlier, if they were affected by NSAIDs, including Spiro, the one I mentioned, rheumatoid arthritis had a higher incidence rate of GI symptoms. So this is the most recent meta-analysis that I saw in 2014 by Naroom, much larger sample size than the prior meta-analyses. And overall, they found about 2.9% corticosteroids risk rate versus 2% in placebo. And this finding was only significant in hospitalized patients, which kind of goes back to the point way in the beginning about stress ulcers, because stress ulcers are much more prevalent in the inpatient setting because of critically ill patients specifically, people that are on the vent, people who are in sepsis and shock where they have decreased gut perfusion. So these are all possible confounding things that are affecting the ulcer rates in hospitalized patients. So kind of in summary, tying things up, all the studies I've seen kind of go back and forth, and it's really important to kind of figure out the underlying thoughts behind everything, because we need to figure out who we should put on prophylaxis. And specifically, corticosteroids and NSAIDs seem to have a synergistic effect. So whenever you're having one or the other, be really, really cautious about instituting that combo drug. And in the inpatient setting, as I mentioned, there's a lot of confounders, but because people are on polypharmacy, you just really need to be careful of what else you co-prescribe with steroids. And overall, this kind of topic was very, very difficult to study. Most of the stuff that I looked at was retrospective. There's poor diagnostic criteria, partially because ulcers can be asymptomatic. And what I mean by that is people Some of them were being diagnosed based on symptoms. So if they're asymptomatic, they actually might still have ulcers, and that could totally throw off all the studies that I've mentioned already. Overall, though, it does not seem like corticosteroids have ever been proven to be an independent risk factor. It was always in combination with another drug that led to bleeding in all the studies that I've seen so far. However, theoretically, if you're on higher doses on longer duration of corticosteroids, you're inviting in other actual independent risk factors like NSAIDs and H. pylori to kind of synergistically lead to increased ulcer rate. And overall, in all the findings I've seen, there's a very, very low rate of GI ulcers and bleeding across all these studies. And there's no clear consensus, but once again, it does not appear to be an independent risk factor. So kind of to end on a hypothetical situation, I'm an intern, and if I was capped about like 10 new patients a week, let's say, and unfortunately maybe working for 30 intern years, I would have about 15,000 patients. And using the prevalence of about 4% steroids in the population, you end up getting about 600 patients on steroids. And based on the rate of steroid-induced ulcers, that would be about one patient with a steroid-induced ulcer. So, I mean, after kind of calculating all that and doing all this research, I kind of feel like they've been kind of going back and forth for decades for not a very significant reason. And that's it.
Any comments from the peanut gallery? Yeah, Lynn?
I think one of the things that's difficult to tease out is the effects that things like aspirin are having on someone who already has a mucosal lesion and therefore starts to bleed once you add the aspirin. And that's going to be a different question than actually causing the pathogenesis of a new ulcer. And I think probably what you found was that over 50, 60 years, this myth has existed for so long that that's maybe an impossible thing to distinguish, other than maybe in a rat or an animal model.
Yeah, it's really difficult. Like, you would have to literally image them ahead of time with like endoscopy. Oh, sorry. You would have to, do like a prospective cohort where you actually look inside people within a gastroscopy and see if they actually have any lesions at that time, and then start them on it. And that's pretty unfeasible, just because you're not going to want to do that to normal people, unless med students, I guess.
Enter.
Yeah, cool.
Any other questions or comments? Yeah.
So does this myth apply to inpatient or outpatient, or overall, or combination?
So overall, as I was saying, in hospitalized patients, it seems like it's most likely from a different thing. I can't rule out that it's actually causing it. But in all the studies, not including that last meta-analysis I mentioned that looked at hospitalized versus outpatient, but they never really saw it as an independent risk factor. It's usually from the other things I mentioned, NSAIDs, H. pylori, and also just the critically ill people who are in shock, not perfusing their gut, maybe have reflux bile acids and uremic toxins into their gut, leading to ulceration. Yeah, so I mean, just kind of sum things up a little bit more. This is just talking off a base of everything I've read so far. It seems like things that actually cause ulcers that are independent risk factors are things that weaken the mucosal barrier, and there hasn't been things that show that corticosteroids do that. It shows that they increase acidity, but acidity in itself is already buffered by the barrier. Unless the barrier is broken down by another mechanism, you would develop ulcers that way.
But I felt like steroids also delay wound healing or maybe the regeneration of the epithelium.
So if you did have damage, that's why I was saying it's not an independent risk factor, but it can propagate other things that may have caused it.
Which may be why, with nonsteroidals, when you get an ulcer from a nonsteroidal and then you add the corticosteroids, it may prevent it from healing, so it has a greater tendency to bleed or not go away because it's just not healing. But that's different than the actual cause of the ulcer in the first place. Okay, it's time to vote. So, how many people think that corticosteroids cause ulcers and GI bleeding? How many think that it's plausible still, in spite of the evidence that's been presented? So 3. And how many think that this is busted? They just want to see the explosion.